Whitney? Do you see something that I don't? No.
Nope.
Maybe she'll get it. Yeah, and I don't see the thing in the flash drive thing. That's my early morning vocabulary.
It's okay.
The thingy and the thingy. It's not there.
But the thing is, people understand that, right?
You did, didn't you? Yeah. Do you prefer lavalier, podium mic? Okay. Waters if you need it. Good morning, everybody. We're going to get started in about 2 seconds, so if you want to come on in and take a seat, please. Lil, do you have a sense of how many more people are coming in? Really? Other side.
Other side?
Mm-hmm.
Oops, sorry. Is it detecting it? It's usually, but you're in presentation mode, so that's probably why we're not seeing it. Yep.
Okay.
All right.
Yep, it's good. Thank you.
All right.
All right.
Welcome.
Okay. Good morning, everybody. We're going to go ahead and get started. So how was yesterday? Go okay? All right, well, I would suspect, given our sort of thinning crowd, that I don't need to ask who was out too late last night. Liliana Johnson. So thank you all, your troopers, to come in and start with us early in the morning. Let's see, I wanted to check in on our Kaizen folks. I want to see how you all are doing, because this is day 4 for the Kaizen folks, and as soon as we're done today, they're going back into training. So you all got plenty of coffee? Ready to go? All right, good. How many of you all met somebody new yesterday? Awesome. How many of you all participated in the PH Kicks question answer thing yesterday? I thought that went pretty well. What do those of you that participated think about that? Was it a good way to meet people, or were you just in it for the iPad? And really, there's no shame in that. I would be in it too, but I'm not allowed to since I'm, staff and stuff. Okay, so just a couple of things before we move on to our first presentation of today. The first thing is, when we come back together in a closing, we're going to do just sort of an informal discussion and check in with everybody. And so I have a few questions that I'd like you all to consider before we come back together this afternoon. And those questions are, when you were here with us, did you have any kind of aha moment that you'd be willing to share with the group? Did you have any surprises? Did you learn anything new? And if the answer is yes, don't just say yes or no. Say yes and here's what it is. And then what are your next steps after you leave the forum with the information that you gathered? So we hope that you'll take a little bit of time to share that with us, and also be letting us know if there's some information that you didn't get or that you want to follow up on, that you can let us know about it then, and we can help you do that. A couple other announcements that I have for you is that there's going to be a taxi sign-up sheet out by the registration table. We'll put various times, so if you all want to share a cab to the airport, please sign up there and help save costs. Also, for those of you that are gluten-free, there's going to be a special plate for us. I'm one of those people. There's going to be a special plate for us, and we just need to let the server know that we are gluten-free and need to ask for that separate plate. Want to make a final plug for the evaluation. We've always had a really good response, and we really use that information to make changes and improvements to every meeting. So please fill out your evaluation. Let us know how we did, what can be improved, what worked well, what didn't work so well, and we'll take that into consideration. And you'll get a flash drive of all of the meeting material. So we hope you'll take the time to do that. And finally, I want to make an announcement for a save the date. Our very next open forum meeting is going to be in June. We haven't determined the location yet. There's a couple contenders, but we don't want to announce it because we're not 100% sure yet. But on June 10th, we'll do sort of the pre-conference training workshop or workshops. And on June 11th and 12th will be the actual open forum. So I hope you all will consider joining us again. And if you're interested in coming, just let us know. Okay. So with that, I am going to pass the microphone over to Jessica Riccardo, who is a program manager with the Louisiana Office of the Louisiana Public Health Institute, where she supports their primary care capacity project. She is going to help kick off our introductory speaker this morning, who's going to share about New Orleans transformation, which is really an incredible story if you haven't heard about it. So Jessica, I'm going to go ahead and pass it to you.
Thanks, Jennifer. Good morning, everybody. So happy to be here back with all of you at the Open Forum. This is my 4th or 5th Open Forum, depending on if you count back when they used to be the multi-state learning collaborative model, which I actually attended in my first month or so with the New Orleans Health Department. As Jennifer said, I'm now officially with the Louisiana Public Health Institute working on projects there. But I spent the last 2.5 years as a transformation manager with the New Orleans Health Department, working on a wide range of aspects of our transformation, which Charlotte is going to talk to you about in a little bit more detail. But I just wanted to say, at the start of my role there, I attended the MLC and the Open Forum. I went to some trainings put on by CDC about MAP or the National Public Health Performance Standards Program, and I have to be honest, it was, for any of you out there who are feeling overwhelmed or confused, I was right there with you at the time. It's totally normal. It's a lot of information. It's a lot to take on. You're looking across this field at the national level and trying to figure out how you can bring that back to your local context. And these open forums have been absolutely crucial for me to be able to do that, to learn from national leaders and then everyday practitioners that come to these events and share lessons learned and talk about their experiences. And I feel very, very lucky for this. So thank you to NMPHI, Robert Wood Johnson Foundation, for putting these on. Really appreciate it. I just want to also say that in addition to having this external support, we were incredibly fortunate at the New Orleans Health Department to have the amazing leadership that we had. Patience, tenacity, grace under pressure. These are all characteristics of Charlotte Parent. You're so lucky to have her here to tell the story today. She rose up from the director of the Healthy Start program within the health department and was responsible for keeping the department afloat during a time when the city was actually considering dismantling or disbanding the department. She was able to hold it together and bring us through to a point where we could start to talk about transformation and turn the ship around and create a new story for ourselves. She's absolutely the glue that keeps our department together. She has superb management skills. She's very resourceful. I'm gonna get teared up. And she's just an amazing boss, and I was so lucky to work for her. With that, I will let her come up and tell the story.
Well, good morning. My name is Charlotte Parent. I am the proud deputy director of the City of New Orleans Health Department. And before we get into the transformation of the department, I just want to give you a little background of where I came from. I am an RN, did direct services for almost 18 years before I moved over to public health. Ran the maternal child department of one of our city hospitals up until about 6 months after Katrina, and kept the job, did the work, built the department, and got to watch how we performed during the storm, and got to watch how clients utilized the system or had no system to utilize or had no capacity to do the things that they needed to do to be to survive, frankly. And so for me, it was a turning point to say, okay, I've been working in this and I'm helping to deliver babies, but then I send everyone out, and what are they going home to? What are we doing upstream to make those changes so that they have what they need to be able to function? And decided that for me, the role needed to be in public health, and decided to move from direct care. Had an opportunity to move into the health department, continue to do work with maternal child, which is my love. Everyone has something that is special to them, and that's mine. But when we started to look at what should that department look like, and that question was being raised, do we need a city health department? By that point, I had done that job for about 3 years and realized, yeah, we needed a city health department. Were we focused on the right things? Probably not, but it was important. So began that fight until Dr. DeSalvo was able to join us to pick up the mantle and figure out where we go from there. So this is a story of how New Orleans has changed and has really decided to focus on the public's health and not just on those direct services. So the agenda for today for us is to give you the background and the department history and why the need for change, and then to walk you through our transformation process. How did we stabilize the environment? How did we transition from direct services? How do we begin to plan for the future and develop that new department identity to make us move forward? And then finally, the lessons learned. So the City of New Orleans Health Department has a very long history. We are over 215 years old. We were one of the first, if not the first, and we can't really know that, but to have developed an unofficial Board of Health and have a Board of Health that was situated in New Orleans. And basically, as all public health entities, we focused on things to protect the public: quarantines, infectious diseases, sanitation. And as we move throughout history, those are things that continued in the health department. But Katrina, as everything does, changed for us in terms of what did we need to do and how was that city going to be structured, and basically wiped out and gave us an opportunity to redesign what we wanted it to look like. So as we did some of our cleanup, which you're going to see some other pictures from that, but you know, if you have an old health department, more than likely you're hoarders. There's lots of things around, lots of things to find, gems that are there. And one of the gems that we found when we were digging, literally through boxes of papers and old stuff that was just held, was an album of old pictures that had been taken through the city health department of some of the services that they did. So again, the pictures that you see, one, the map, there was GIS mapping in 1937. It was manual at the time, but it mapped out where all the births happened in the city so that you could look at that and see where did you need to focus your attention. Home visitation, which is back, right? And important, and now being talked about as being one of those things that the health department should do or we need to do to change the paradigm of health, was going on. Whether or not it was seeing families at home or teaching and those sort of things, it was what we did. Quarantines, lady putting up a sign for typhoid. So these were the things that the health department did. We also provided direct services, and these are a few pictures that we found of some of the direct services provided. And as probably in all health departments, a lot of those direct services focused on children and families. Immunizations, well baby care. Again, these pictures tell our history. One of the pictures is of one of our segregated clinics at the time. And it's such a pleasure to look at these pictures and see that history and understand where we came from and what goes on. So it talks about, you can see that they're providing services in one case, and there's a class going on, a group class, sort of like centering pregnancy, centering parenting. So things that were old are new again. And that's probably what happens in public health all the time. Things just cycle around. So the Katrina recovery held us or made us look at things and figure out what did we need to do. So clinical services at the time, again, the city ran prior to this 15 health clinics prior to Katrina. What was left after Katrina were 3 clinics that had not been damaged by floodwaters. So we had 15 clinics, and most of those clinics were flooded, meaning that everything in it was wet, destroyed, needed to be gone through, cleaned out. But basically there were 3 clinics that were left to function. And part of what was going on is the federal government assisted us in standing up what had been prior to Katrina a struggling enterprise to put community health care out there. And after the storm, there was this, the thought that, you need to get this in place and get it going. So they assisted us by putting a waiver program in place for us to stand up community health clinics. Those were going on, and with that, they also gave the city some dollars to work towards their clinics and get those going. So all these things were happening at the same time. Also prior to the storm, emergency medical services sat under the health department's administrative arm. After the storm, even though the charter still says they sit in the health department, the administrative arm of this now moved to Homeland Security with the Emergency Preparedness Group and Public Safety. So they are now tied to police and fire, EMS, and Homeland Security. Our other programs that were major, players for us in providing services was our Healthy Start and Ryan White program, which at the time were run by not-for-profits for the city. The city received the grant, we then pushed it out. And after the storm, the decision was made to bring those programs back under the direct purview of the city. So the city ran those programs and got them off the ground. And those were some of the first programs that came back immediately after the storm. Went out, tried to find where the clients were, as far as cities outside of New Orleans to Baton Rouge, and there was a large contingency of our clients staying in what's called Renaissance Village, which basically was a FEMA trailer park. And we then started our outreach there to get things to them and do what we needed to do. So that was how we first got back. The Healthcare for the Homeless program was under HRSA review at the time. Lots of indicators that needed to be addressed, services that needed to be addressed, and quite frankly, was not performing where it needed to perform. So that was something else that was sitting there that we needed to fix. And then at the same time that all this was going on, the state had made a decision that they were not going to operate WIC clinics anymore directly. And so it was one of these things where we were trying to make a decision on whether we were going to continue to operate clinics, WIC clinics, and the state was like, oh, we're thinking the same thing, right? The problem was who was going to service the clients. So we then made a strategic decision that we would continue to do WIC services because that was a point of entry for us for those clients, and we wanted to make sure that we did not drop that safety net. So in 2010, the city went under new leadership. Mitch Landrieu was elected mayor, and Dr. Karen DeSalvo was appointed the health commissioner. And when she came on, there were three main goals that she had decided for this department that we wanted to focus on. And one was to advance the health department into the 21st century. Bring data-driven approaches to strengthen how we work with the local healthcare system. And then finally, to begin to embed health in all policies at City Hall. So the need for change was great, and as most things start out, it's not just about the philosophy of what it looks like. They're driven financially. And when the city started to begin to look at what was going on in the health department, we realized that the little city budget we had, which at that time was $1.5 million, was being eaten up by doing direct services. So that money, in conjunction with the grant funds that we had to run primary clinics, a total of $4 million, was basically being used to do 3 clinics. And no other public health services were really happening at the time. But there were serious public health threats out there that we knew we could not address just from direct services. And those were violence, which is what we consider our #1 public health issue in the city. Obesity, which can be directed in some cases by direct care, but we know a lot of that is behavior modification, and how do you change that? Low birth weight, which we had worked going towards that, but again, not focusing on how do you change that by the population. And in poverty, which is just the social determinants that were going on, and direct health care wasn't going to be our way to make that difference. So a decision had to be made on where were we going to put our focus, and do we continue direct services at the detriment of true public health, or do we make the switch and really start focusing on how do we get the public's health where it needed to be? So we set out with 3 transformation objectives. First one was to transition ourselves out of direct clinical services by July 2011. Now realize this decision was made in January of 2011. And everyone we talked to, because we went out and talked to people and said, okay, how do you do this? What do you do? When we would tell them what our timetable was, they would go, yeah, right. We've been trying to do it for 4 years. We've been trying to do it for 10 years, 20 years, whatever it was. And if no one knows anything about Dr. Karen DeSalvo, when she says we're going to do something, then we do it. We figure it out and we do it. And so we set our goal to do that by July 2011. Then, at the same time, start to figure out how do we build that capacity to address population health. And for us, that was going to mean major transition of the types of employees we needed, building public trust around that we weren't going to do direct services anymore. And so all this was going on at the same time. And then, oh, by the way, we were going to be accredited by 2014. And originally it was the end of, November 2011. That was Dr. DeSalvo too. And Jessica and I were like, okay, in between everything else, we're going to do that too. We're naive enough, okay, we'll figure that out, right? So we put that there, but in time we realized, yeah, no, that's not going to happen. But we will achieve that by 2014. So transformation level of effort for us. In 2011, we spent most of our time stabilizing the environment, literally just trying to figure out what was where. Who had what, who did what, who, asking people, what's your job, right? What do you do for us? And trying to get them to really give us some substance on what it is that they did and understand how that fit. Then begin to establish the fundamentals. Again, we had a lot of direct service providers in our clinic who probably didn't know a lot about what public health was about, right? They're out there taking care of patients, and they will tell you they're in public health, but did they really know what that was for us? So it was about how do we really get back to understanding what that needs to be. Building capacity to do public health, and then finally addressing population health. And over the years now, we have moved to where we are now where we hoped we would be in 2014. We don't spend a lot of time now stabilizing the environment, right? We're still cleaning up. That's still happening. There is, over 100 years of stuff. So that's still going on. But we have now flipped it, that most of our time now is truly looking at how do we address population health. So seemingly simple tasks were difficult. Trying to find out what the department budget looked like. Okay, you'd ask the accountant to tell me what's this and where's that, and they were talking, okay, that's R code 3613. What's R code 3613? Tell me, stop telling me 3613, tell me that is WIC. Tell me that is, I need to understand that. How do you spend? How do you do this? How do you do that? And realize people were a little, hesitant to let go, right, of that information, because where is that going to take me? If you know all that, right, what does that do for me in terms of my job? So there was a lot of that going on, but we kept probing, kept asking, aggravating people, and eventually people understood we were just trying to understand what it was about. The inventory of supplies and equipment, again, 15 clinics, 15 places where things were hidden, right? And we had no idea what we owned and what we didn't own. We had no clue. There was a time after Katrina where the money was coming in for us to set up clinics, and so they were buying equipment to do that, but the facilities were running behind because of FEMA money, right? So they're getting equipment, trying to get ready to stand up, and there was nowhere to stand anything up. So when we got there, we would find things in a basement and things stored here, and I'd just have boxes. And it's like, what's in this box? And you always a surprise, every day a surprise. How do we pay the bills, right? Are we doing it correctly? We had vendors calling you owe us money, the bills weren't being paid, they weren't being processed timely. What's that system and how do we do it? How do we collect payments, right? We were running clinics, but nobody was really collecting any money for the work that you were doing. And so we had to figure out how much money was sitting out there that we could still get our hands on to try to do the things we wanted to do. And so spent a lot of time trying to figure out billing and how does that work for us. And then managing of patient records. So it's the city health department. You have all the records from 15 clinics. You have all the immunization records, right, for the city. They're all sitting there, and we opened a door one day, and there's this old machine. Some of you may know what it is. It's called an Electriva, right? And it's one of these things that you put the cards in, and you press a button, and it spins around and spits out a drawer. And in a drawer is thousands of pink immunization cards. I found my immunization card in there, okay? Famous people who lived in New Orleans were in that Electriva. They were just there. No one had touched them. And that was the ones that were at City Hall. That's not the ones that were out at all the clinics. And we had some fantastic help from the CDC to help us kind of quantify how many immunization records that they were. And at the time, the number was close to, I think, 400,000 immunization records that we needed to do something with, that we couldn't just destroy. We had to figure out what's going to happen with those. We had outdated technology systems. We had cumbersome bureaucratic processes. We are city government. Nothing moves quickly. And finally, management challenges. Again, everyone who worked in the department primarily were hired to do specific jobs, but no one had really been trained to manage. And so you're asking them to think broadly, and people just did not have that capacity to do it at that time because they weren't trained to do that. So here's one thing that we did, case study of records. So one of the doors that we opened, this was the records and supply room down on the first floor of City Hall. So this is the view you saw when you went in. And this room had supplies, it had records, it had just stuff, it had bleach, it had everything. Anything you could want was in this one room. Then we got a call, and we found records, all right? And every time we thought we had found everything, someone would call and say, gee, we're out here working at this rec center in the lower 9th Ward, and there's records for the health department. And I would go, no, there's no records out there. No, when they demolished that building, I was told all those things were taken care of. No, Charlotte, I think you need to come out here and look. And they would open the door, and it was a sea of records that literally had been picked up from the buildings they were going to demolish, brought there for safety, right? But then no one told anyone that they were there. So I thought we had a handle on it, and then I find out, no, we don't have a handle on it. And to this day, we are still finding records that are somewhere. But this is what it would look like. You would walk in, and this is what you would see. Now, we've created a record retention system. We are the first department in city government to have an approved record retention record policy with the state. So we can now get rid of records that no longer need to be there. We can destroy. And then our next step, now that we've organized it and we know what we have, is to begin to figure out how we can scan these records. What can we do to get them where we don't have all this paper anymore and put it up? And we've really created a system now that a lot of the records, since we've stopped direct care, are going to start to fall off, right? That we don't need to hold them anymore because we're not seeing patients. So we've created a system to periodically and annually purge the records out. So hopefully at some point we won't have any records, but at least now you can find them. You couldn't find them before, and if anyone asked you to search for them, it's near impossible. So the direct services was the big one for us. We needed to identify quality, affordable alternative providers for our clients, and then set those transition deadlines, and then communicate with everyone what we were doing and why we were doing it. And when we say communicate with everyone, it really truly meant everyone, whether it was staff, the patients, the city leadership, the state health department, the public, and then the press, so that the message got out correctly, that we weren't abandoning patients, but we were finding better quality services for them and making a true match for them. And then finally, how do you measure that and track the patients that we could track to see how we did, and did they get where they needed to go when we made those referrals? So the results of this was that over 98% of the patients that we could track in a 9-month period made it to those clinical transitions. We had providers who would sit in our clinics to make sure that people got registered and information got transferred. We would then contact them if people were sent to a clinic to make sure that the referrals did happen and the person did show up, and then checked with the patient to make sure. The final validation for us, though, was with the state Medicaid office. And they helped us by giving us information to show us that those patients had transferred to another provider. So we were able not only anecdotally to understand that the job happened, but we were able to measure it also and say this is how it occurred for us and this is what happened. Now, the other results of this is, of course, we had a reduction in FTEs. 35 FTEs who were working those direct care clinics were no longer with us. But part of the transition was to find as much as we could safe landings for them. So our providers who had positions took some of our employees on. Some retired. They had been there for a very long time and weren't ready to take on the challenges of that kind of change. And then others, we moved to programs we were still operating, like the WIC service. If we could make moves, we would move people into other positions within the department to do that. In 2011, we saved $700,000 by doing this. And had we not done that, the city would have, in the next year, because we would no longer have had those grant funds, had to have come up with money, and probably not so much come up with the money, because at that point in time, the city was running in the red, and nobody was really looking, right, to say you're running in the red. They may have continued the services and continued to create deficits at that point. But we stopped that in the health department and stopped the bleeding. So this is our timeline on what we did. We transitioned to clinics by July 2011. We met our goal. At the same time, we were working on that transformation plan. What does that look like for us, and where are we going, and how are we doing that? Working on a reorg plan. And then once we did that, focus on how do we hire the right people to really start doing the work of public health. And that took a long time. And the reason it took a long time is because we're dealing with civil service systems. And so the positions we were trying to put in place didn't exist. There were no positions out there that really fit what we were trying to do. So we had to create positions, go through the process with civil service to say, yes, it meets the need. Then they became classified employees and trying to recruit the right people. People get on the list because they've tested high, and then when you interview them, they're really not the right people. So we did a lot of, redoing, editing, figuring out what it is, and it really took us about a year to get the right positions in place. And still to this day, we still struggle with some of that because there's layers you have to go through, and it's the bureaucracy of what we do. But they were willing to work with, at the beginning, it was hard. It was out of the box, and they were like, no, can't do that. But now the relationship is different. The relationship is, this is what we're looking for, this is how we need to do it. We figured out ways to work the system to try to find the best people. And they are helping us to do that now rather than just telling us what we can't do. So that's a good thing. The whole time we started putting in our performance management system, measuring the things that we needed to measure to understand that we were making that progress. And in October of 2013, our Quality Council was established. And this was a combination of our accreditation team members, but primarily people in our department who were interested in quality. And we invited anyone we thought who had an interest in that to be part of that team. And our staff responded to that. While we're running with all of that, we began our community health assessment back in July of 2011, and that process took about a year. The CHIP was put in place, the strategic plan was done, and then in February of 2013, we submitted our FAB application, and in July, we submitted our documents. So we used that process to guide how we would transform, but also keeping that timetable so that we didn't lose any we wouldn't lose any of the gains that we made to make the changes that we did. And the staff was involved with this from the beginning. So we couldn't do this by ourselves. This could not happen without partners from outside of the city government, nationally as well as locally. Whether or not that's the Louisiana Public Health Institute, Robert Wood Johnson, and NPHI. I mean, these are partners who understood what we were trying to do and gave us all the support and technical assistance to do that. The CDC has been fantastic for us in terms of helping us with public health fellows and associates coming to do some of this work because we did not have the capacity at that time to say, here's a staff member to do it. PHAPs would come to us and we'd say, okay, you're working on Fitnola. You're gonna create Fitnola. You're gonna help us understand what that was. And we have been blessed with that we have been able to help guide what they do, but they've been given an opportunity to truly help us create what that looks like. So the transformation plan focused on assessment, policy development, and assurance, and how we did it, in terms of internal management to find that capacity and organizational skills. The communication needed to be really clear. In the beginning, sometimes it wasn't, because we didn't understand how to communicate with all of the staff we had and how to get that information out. Over time, that has gotten really better to understand that we all have to work together to make that happen. We had, project managers and grant managers who were very siloed, worried about their grant and what they needed to do for that. And we had to change that culture that you stand alone. You do not stand alone. You stand with us, and the work that you do helps to support the big picture of the health department. And I think we've made some good progress with that. Policies and procedures. There were a lot of policies and procedures that were about direct care, right? Not a whole lot about how you operate administratively and what do you do. And people assumed that these things were in the CAO policy memorandums from the city, but when you would go to them, they were either very old or they didn't address the issues we had. For instance, things like measuring or time and attendance. What's a tardy, right? When I called civil service, where's the policy on attendance? And they would say, oh, each department creates their own. Really? We all can make that up for ourselves and figure that out. And some departments hadn't done it, right? They just didn't. So we had to create all those things from scratch and say, no, for our department, this is what stands and this is how we do it. So we did that and then created our fiscal policies on how we produce things and how do we move things through the system, and contractual policies. So really it was about from the ground, how do you do this? Then we developed a workforce development plan with the employees, asking what did you need? What did we know we needed to get them to public health? And so we worked with them doing surveys, what's the kind of information you want to learn? Some of it was as basic as computer skills. A lot of our employees just didn't even know how to run Excel or how to use Word, how to read their emails, right? Things are going to the email system, and I'm thinking I'm communicating, and then I find out they never opened the emails to know what it was. So we had to back up and say, okay, that's not the way we can communicate now with you, but eventually you have to move to this. So let's help you learn how to do that and get into those systems. So right now we are citywide putting in a new payroll system that's electronic, and I'm not looking forward to that. I spent last week going around to different clinics just asking people, have you gotten on the system yet? What system? Okay, this is like the beginning all over again, but we'll get through it and they will get on the system and we will have payroll, yes. 5 minutes, I'm sorry. Okay, so main thing for us is to facilitate link and leverage. We had to brand ourselves to move away from doing the things to hold hands. We are now the person that becomes the neutral convener. If there's an idea that we want to make sure happens in our city, we're the person that brings the people together for that to happen versus actually doing the work. Spent a lot of time branding, changing what we look like so that people didn't think of us as the old health department, but this is how the new health department will look. Then we decided what are the things that we needed to focus on and built our strategic plan around that. So improving access to health care, extremely important. Promoting healthy lifestyles, so our Fit NOLA program came out of that. Preventing violence. The mayor has an initiative called NOLA for Life, and the health department is one of the pillars for prevention. Enriching family health, and that we've done through our programs, WIC, Healthy Start. And then preparing for emergencies, which is just, for us, it is something that is extremely important, and how do we do that? With all of that, after we developed the plan with the performance measures, we then put the information and documented it. So for all of the actions that we have, there are plans and information out there in books to put that. So you can go to our website and you can look at any of our strategic pieces and you will find a corresponding document to go with it. Our Children and Families Report will be coming out in December to correlate with our family health piece. And then we went from 2011 with 3 performance measures, because at the time the city linked it directly to budget, so it was really about counting. And one of them was to increase the number of environmental inspections, which we didn't even have environmental under us anymore, so it's not something we could measure, to now where we have sets of indicators for each of our performance measures that we are measuring against in our strategic plan. And some of them, it's still counting, but a lot of them are about how have we moved the ball forward for us, and who are we partnering with to do that, and how do we measure that and putting that out there for the public to see. So the successes have been that since we've done this, we've had over $1 million in new grant support for department and community programs beyond the general fund. Our money is not coming from the general fund. We're going to have a base amount of money, and that's probably all it's going to be for a long time. If we want to grow our department and focus on the plans and the activities we want to, we're going to have to find the money to do that. So we've started, and we've been doing that, and that's been great for us. We've created strong partnership networks, whether or not it's nationally or locally. All of our local partners in particular, they know what we're trying to do, and they know they're going to get called, and they want to be called. They want to be part of this. They want to know that they're making a difference for the whole community. New innovative initiatives under emergency preparedness. We've been working with HHS and CMS to look at Medicare data in an emergency to help us map where clients are that have special needs, especially for electric-dependent equipment, oxygen, and dialysis. So if we have an emergency, we can notify them. They will provide us with Medicare data on where people are located, and then we can find them if they have not opted into us, to our special registry. When we did a pilot exercise in the summertime, and we were able to get the data from CMS, and then we put teams out on the street to go make sure that the people were where the data said they were, and they were. And so it allowed us to go out and register those people for the special needs registry, but also create that relationship so that when we had an emergency, we would be able to make that work. In 2013, we were a Robert Wood Johnson Roadmap to Health Prize winner for our work in transformation and in particular our work with our Fit NOLA initiative on childhood obesity and physical activity. And we were extremely proud of that because, it was in the first group. So it was kind of cool to have someone recognize that all the hard work that was going on was something that was transformative. And we are on track to be hopefully accredited in 2014. We have our site visit in January. And so we are looking forward to that and hopefully achieving that goal. So the lessons learned. Internally, the first thing is hire a transformation manager, okay? This work cannot be done with the day-to-day work that you need to do. It is very, very difficult. There needs to be someone while you're working on the chaos of all the time, all day long, what's going on, who's sitting in the background, Ms. Jessica, and saying, okay, I know you have that crisis, but we still need to do A, B, and C. And she kept that ball rolling and kept us focused on how do we do that. So that's an extremely important piece, that you have someone that's what they're dedicated to do. We were lucky to have a grant to allow us to do that. And I would suggest if you're looking to do this, look to your community and see if someone would help you fund that work to make that change. Be persistent with other departments. It's sort of in City Hall a running joke that, the superstars are in the health department and they're going to be coming around, and when they come, everybody goes, oh, health department, yeah. But we get that at first, and then it's like, okay, what are y'all doing and how can we be involved in it? We want them to think about us when they are doing something, to say, what would the health impact be? And how do we do that? And so we've begun that with our departments, and eventually, hopefully, it becomes just part of the nature of what we do. Provide those opportunities for staff input and also for the community. Don't let them not be part of what you're trying to do. You cannot build something if they've not been involved from the beginning on what you want to do. We assess and gather data and make sure that we are tracking things. Mental health was a big piece for us, and availability and capacity. People thought there was no capacity, but then we started tracking it day to day. Where were the beds available? Where was outpatient services available? And again, that's our role as the facilitator, to make sure the information is going out and have people talking to each other about how you make that happen. The assurance part. With the change in direct services, there are now over 52 clinic sites that are primary care providers in the city of New Orleans, so that we don't need our 3 clinics anymore. There are people there who are doing this, and our role in this is to assure that they are where they need to be, map them out, And if we don't have services in a certain place, encourage people who are trying to put services in to maybe go to those areas and not clump things together. So this has been working well for us, is that person standing back and just looking at the big picture. We have taken on the role of enrolling people in the waiver program. That's our role in the city, is to make sure that the citizens know about it and enroll in it when they are qualified to have it. We do have a patient navigator program that we're using to help people navigate the marketplace at this point. Our focus right now is on the service industry. We have a big service industry in the city and who are not insured, and our goal would be to make sure that those groups of people know about it. And then the medical special needs registry. Health and all policies. We are part of the Complete Streets Advisory Council. This is a picture of our recent cyclovia that we've had. And Livable Claiborne Communities, which is our first health impact assessment project pilot. It's being built, and we are involved in making that happen. Health impact assessments and ordinance modernization. We have many, many, many old ordinances, and we have continued to try to work our way through those ordinances to bring them up to current dates and things that we do now. It is a process and it is a challenge, but we are doing that. Performance management all the time. It's just part of what we do. It's not anything special, right? It's just the norm. This is what you do and how you measure. Aligning the sectors, designing interventions across the life course in our family services, and then engaging in rigorous evaluation. That's it. Thank you.
Thanks, Charlotte. That was really exhilarating for me to sit here and to listen. You know, I've told parts of our stories at these events, but it was really great to hear it from you. So thank you. In the interest of time, I'm just going to open it up to the floor. I had a few questions prepared, but I think we have about 15 minutes, so we'll just take questions from the crowd right now.
Hi, over here. Here I am. Okay. Thank you for that. That was wonderful. I'm curious about the transformation to where you stopped doing primary care. Can you talk a little bit about how you actually made that happen? What kind of clinics you made agreements with? If there were issues with people maybe not being able to get into those as quickly as what they could get into the health department, and how you address those concerns, because it's something we've looked at also, and you know, there's been some pushback, but clearly it's a big money sink. So
yeah, I think the main thing we did was focus on clinics that were in that community health care network. People who were partnered with us already, who understood. There's a group called 504 Health Net in the city, and it's those primary care providers. It didn't hurt that Dr. DeSalvo ran that program and was the chair of that. So when we went to the partners and said, look, this is what we're trying to do, and we want to make sure these clients get attached, they were open to it, and they had capacity to do it. So it really was an issue of, we want to see it happen. How can we help you as the new provider make that happen? Can we make sure that we get these clients in, and talking all the time about, did they come, did they not come, who made those things, and our staff also working on that. So we may not have had agreements to do it, because if you think about it, it really was a referral, right? We want to refer this client to you to have those services. But it wasn't just sending them with a piece of paper. It was making those connections beforehand and saying, look, we have this many clients who need this service. Are you willing to take this on? And then they were. You know, it was like, no, this is the right thing to do. And amazingly, the other piece to that is, when we did all this, there was no pushback from the community. Okay, so when we first started, it was like, oh my God, no, that's the safety net, right? No, you can't remove the safety net. And it's like, well, one, we won't remove anything that we can't make sure we have the right place for them to land. Dental was a good example of that. When we started this process, we had a dental program, and we could not find a safe place for dental to land. So we held on to dental, and we subsidized it and did what we needed to do, all the time looking for a partner. And when we found a partner, we then transferred that off and measured that. And that has become very successful for us in providing what we needed to provide for that program. So it really is about creating that relationship ahead of time, finding the easiest way to make that relationship work, because you could get tied up in the bureaucracy of how do you do that. And sometimes it really isn't about the bureaucracy. It's about just asking the question, can I do this? Will you accept it? And both parties agreeing that it can happen, of course, along with the patient, right? The patient saying, yes, I want to do that. So all of that was a piece of it.
And I would just add, in terms of criteria, we really looked in terms the bar for quality, focusing on federally qualified health centers, and then geographic proximity as well, so that transportation didn't become a new barrier or challenge.
Thank you. Is this on?
Mm-hmm.
Lovely talk. So thank you for telling your story.
Thank you.
Now that you've made this shift, I'm wondering what your plan is for informing the health department on your major issues of violence and obesity and low birth weight and poverty, in terms of the data you get and use, the data management systems, the information that provokes action. Essentially what I'm really interested in is how you think about the healthcare partners and their informing systems, like electronic health record systems, and their ability to inform you about the social determinants of health. What's your strategy or thinking even at this point about that?
Jessica and I talked about this last night, that of all the things that we did, we feel that that's the one place that we still got a lot of work to do. How do we get the social determinants and equity built into this? And we focused on that, of course it's in our chip on how we wanted to do it, and we had very animated discussions with the community and within ourselves of how do we address that? Do we embed it, throughout our chip, that it's in everything that we do, but then it's so important that in a sense it should stand alone, in terms of how do you address it. And so I think that as we're moving forward and we get through some of these next hurdles, that's the next conversations, is how do we make sure and what are the pieces and parts that we put in place to ensure that the determinants are addressed. In family health in particular, a lot of what we're looking at is on on neighborhood levels, and the information that's out there is on neighborhood levels, and we've packaged it like that. You'll see in that report that we gave a report on 73 neighborhoods in the city, and we identified those protective factors and, of course, those risk factors that are there. And the protective factors are things like transportation and housing, and it's not about just the medical piece. It's about those pieces that will help you to thrive. And we weighed those things and said, okay, for particular neighborhoods, some of these things are really good. And so when you look at the data, of course, the issue of low birth weight may not be an issue, right, or a big issue, less of an issue. But those that didn't have it, of course, it's a higher issue. And then what we're doing with that is letting that inform where our programs need to work and what do we need to do. And we are one of, if you all have heard of the Best Baby Zone, there's 3 cities that are Best Baby Zone, and the focus of the Baby Zone is to hopefully put in assets that are dealing with economy and health and education into those neighborhoods so that you can hopefully turn that neighborhood around. It's sort of built on the Harlem zone. I can't think of the name, but you know what I'm talking about. So, and there's a lot of work around neighborhoods right now, and that's what some of the work that we're doing. The NOLA for Life plan is focused around neighborhoods, and again, putting assets into those neighborhoods to hopefully change the paradigm of crime in those neighborhoods. So we're looking at it from those levels, but we feel we haven't done our best yet to make sure that we are focused on that. And the community, definitely has to come along with us on this. A very hard subject and a difficult task to put into your systems.
And strictly in terms of data. The New Orleans Health Department does not have an epidemiologist. As a matter of fact, we rely on the Office of Public Health in the state for the surveillance, monitoring, and epidemiological functions, as well as community partners with data. You know, we don't have data warehouses. We do that. We work through partnership for those functions.
Charlotte, I'm Torney Smith, Spokane Regional Health District. Thank you so much for your presentation. It's amazing to me that you have pursued FAB accreditation after doing all of this, when I hear from several that we have too many challenges to get there. So congratulations on that. My question has to do with your reference to WIC and sort of a transition from your comments just now about how did you coordinate with your State Department of Health and determine, like WIC or EPI, how you determine who would cover what?
Okay, yeah, go start.
As you saw in that timeline that we put early in, that has been a long-running question, and I imagine this happens in other states and other areas. What will the city be responsible for, and what will the state be responsible for? And we had the slide about policy and ordinance modernization. Early in our process, we went through the entire municipal code to understand what does it say that the city is responsible for. We also did an analysis of the state sanitary code, and this is where we worked with the CDC public health law program under OSTILTS. And that initiated a lot of questions for us, not just about our relationship with the state, but with other departments in the city. And you get to this question of roles and responsibilities and who's really going to do what in reality versus what is on paper. So we called in our partners, including the state, and we really talked through what's happening today, what needs to happen. I would say the areas where we've had the most back and forth is around emergency preparedness. I think that's the most fully formed. In some cases, we do not have capacity. We don't have an enforcement arm in our department, and so we are really relying on you. Was a struggle. Their budget's getting cut all the time. You know, they're struggling to make ends meet to inspect restaurants, and so, you know, I don't know if any of our FAB site visitors are in the room, but this is, part of this process is seeing your weaknesses and knowing areas for improvement. That's definitely an area for us to keep working on.
And I think one thing that I forgot all about that. Yes, we did that too. Which was really interesting, right? Because again, you found out things that you just like, that's written, that's what they used to do. It's just amazing what you can find. But one of the things that now has come out of that, after Katrina, environmental health, which had been under the health department, was put under our blight properties that were out there, because blight became such an issue after Katrina. And so those inspectors were then moved over there to deal with the issue of blight and houses that were abandoned after the storm. Now, we had a blight issue before that, but it was potentiated. So they were moved over there. And part of, remember I said we were walking around asking people, tell me, what do you do? I can't find a job description. What does this department do so we can know it? Well, when you couldn't define that, right? The administration's like, well, you can't define it, and we can sure use that over here, so we're going to take it. So there was a period where the health department, as Karen says, we were sort of pillaged for a little bit of time, because it was, there was no one there but me trying to hold it together. And if they saw something and we couldn't define what it was about, they would say we can use that to do something else. What's happened now is, okay, the blight issue is still there, but it's gotten better. Now, those issues of quality of life are coming back, and the citizens are crying out for people to come and do things like work on noise, right? Noise is a problem. We are the arm to follow noise. And so next year in our budget, they've added money back in for us to add environmental health, to start a focus on education about noise and other issues, but eventually figuring out what the enforcement is going to look like for the city. So our work has now led to things that weren't there, taken away, coming back, hopefully being able to reorganize it in a way that makes better sense for the department, and frankly, really defining what it is for the department, so when we're not there anymore, whoever comes behind us understands why we did what we did. And it's not just because that's the history. That's what we did, right? So.
Yeah.
So congratulations on the transformation. I mean, it's really a remarkable story.
Thank you.
And I wanted to go back to the transferring the primary care clinics out.
Mhm.
And I was just wondering if you could talk a little bit more about the politics. It's great to hear that the community was behind that transformation, but I'm thinking about the city council, and I'm wondering so if I remember your slide correctly, it was about $1.5 million, something around $1 million plus or minus that you were using for direct clinical services from the city.
Mm-hmm.
And did the city maintain that level of funding so that you could put those dollars into your foundational services? If you could just talk a little bit about that, that would be great.
Sure. So, okay, first, City Council. We had no problems with anyone, right? I think it was a time in New Orleans that everyone was trying to figure out, what are you going to look like? What are you going to do? How are you going to do it? And we came, and they knew that it was going to bleed. They knew the money was going away, and what do you need to do? So we first went to the community, and we first went to the administration to talk about this is what we think we need to do and why that was important. The other thing that we did was make sure that we knew who those partners were and really focused on the fact that those clinics were quality clinics. They were going to be able to provide better services, wraparound services that we could not provide. And while our staff were good people, I mean, they were trying to do the right thing with what they had and how to do it, we just didn't have the capacity to do it right for the public. And when we told that story to council, the mayor, to the citizens, and the mayor holds budget meetings every August, and we go around to all the neighborhoods and meet, and people, stand up and they throw it at you, right, about what you're doing. And that was about the time we were doing the closing. So we went prepared at those meetings thinking we were going to have to answer for this because this is safety net issues. It really wasn't a problem. The people understood what we were trying to do. And I would guess if it wasn't successful, of course, we would have had the blowback after that. But it was successful because we took the time to make sure that we talked about it. It was planned. It was deliberate. We told them if we could not find the right people to do it, we would hold on and do what we needed to do. Now, as far as the money is concerned, we started off that year with about $2.1 million. So when we did the savings, the budget actually then fell to that 1.5. And that's pretty much where we sit now. I think this year we're going to get 1.6 something, a little bit more. But we are still part of, if the city decides they're doing overall cuts to budgets, we are part of that mix. Our cuts are not as big as a fire department when you do a percentage of it. It's a small percentage, but it's a percentage of money that we don't have to do something. So it sits right now at about 1.6. The money that we primarily lost was about direct care and those direct care services and supplies and things like that to do that. So, it is now what it is. We pay more for contractual services for dogs and cats than we do for people. And we make that point often, too. So, we are always trying to figure out how to do it, but, we're not going to sit there and say, oh, that's all you're giving us, we can't do the work. We're going to go out and find where do we get the capacity to do it and make sure that we're delivering.
And I just want to add a couple things. It's a great question, the politics of it. The part of what was so important in this is that we had a local foundation and we had Louisiana Public Health Institute working with the health department. They saw this opportunity. We have new mayoral leadership. Okay. We have new mayoral leadership and a supportive council, and just the climate was right for this kind of change. And so if this is something you want to do, finding that window of opportunity is really crucial. And we are at time. I just want to remind everyone we're going to have about a 30-minute break, and we're going to come back for another plenary session. So thank you very much. And if you have any other questions, we'll be up here afterwards.
Thank you.